can see it on this slide. This material has been described already in 1934 by Karl Mayer and co-workers. We looked, first of all, with our research group in Bern on some biologic effects of this material. In conclusion, we were able to say that the material is fully biocompatible, no negative effects on the viability of these soft tissue cells. It has an important effect on the proliferation and migration of periodontal ligament and gingival connective tissue cells. And it has also an important effect on the indicators, some molecules that have a very important role in the scarless wound healing, like, for example, TGF-beta3. It also upregulates the expression of genes encoding certain growth factors that are important for proper wound healing. And it has also a certain release in pro-inflammatory cytokine gene expressions. In other words, it initiates cellular inflammatory response. And it has an important effect on the remodeling of extracellular matrix. And then we also looked in a second study that was published only 1 month ago on the effect of bone cells. That means on either mesenchymal stromal cells and pre-osteoblast or also osteoblast. It has an effect on the proliferation of those cells. However, the mineralization is inhibited. In other words, it may keep the stemness of the cells, and these cells may differentiate in different directions over time. In some preclinical studies in animals with our collaborators from Japan, with Dr. Yoshinori Shirakata from Kagoshima University, and we wanted to see whether the effects, the healing, may be also affected in different periodontal defects. We concluded that using this material, we may have a higher chance to regenerate periodontal ligament and root cementum in two-wall intrabony defects. And we moved on with the next study that elaborated on the potential application of this material on recessions. Please observe the differences in terms of new cementum and new bone formation in the two groups. Between the test and the control, you can clearly observe a difference. So we performed systematic review and meta-analysis, and our goal was to try to find out, do we have some evidence from the literature that these materials may have a positive effect on the healing? So in conclusion, in intrabony defects, the application of hyaluronic acid may additionally improve the outcome of periodontal surgery. And for us as a clinician, it is very important to focus on the biology of periodontal wound healing and regeneration. It is very important to understand that we need to stabilize the wound. And the phases in terms of wound healing are always the same. Doesn't matter if I have a non-surgical approach, surgical approach, recession coverage, whatsoever. We always have the inflammation, we have the formation of granulation tissue, and the matrix formation of remodeling. And this very important part of the wound healing is located in the first 2 to 3 weeks after surgery. And we aim with our surgery, with our surgical technique, with our regenerative material, with our connective tissue graft or collagen matrices, to improve and help the body to heal during this first phase of healing. So what is now the treatment concept? We would like to use flat designs that aim to enhance wound stability by avoiding vertical releasing incisions as much as possible. Of course, I would like to use some biologic materials that have a potential to enhance periodontal wound healing and regeneration. very often the tissue is very, very thin. So in other words, we need to increase the tissue thickness and to improve stability. I would like to use subepithelial connective tissue grafts or soft tissue replacement grafts in order to enhance soft tissue thickness and enhance wound stability. And then, of course, a tension-free flap adaptation and suturing is mandatory. So we start to focus since many years on the tunneling approach, and we modified it in a certain way. And let me show you some cases, because I think this is what matters nowadays. So we have seen that we have a potential biological activity of hyaluronic acid. Now we have our patient, and of course we need to have also our surgical technique. So in this particular case, we have a post-orthodontic situation and a very, very thin tissue. We have also a certain insertion of the frenula. And what I would like to have is to prepare the flap, the tunnel, in a way I preserve the papillae as good as possible. I have an internal frenulectomy, and then I move the two edges of the tunnel together. And we described together with my friend, Dr. Pat Allen from Texas, from Dallas, this technique, and we called it laterally closed tunnel. So we mobilize the tunnel, we release the fibers apically as much as possible in order to have a tension-free mobilization. Of course, we use a connective tissue graft, especially in the lower jaw. I always prefer a connective tissue graft because we need cells that are able to produce and to regenerate the soft tissue. This is the application of hyaluronic acid, and my experience with this material was very interesting because I observed that the material sticks to the root surface. You can see it very nicely on this slide. So we have a kind of stabilization of the blood clot, which is a quite unique characteristic of the material. And we know from the literature that one molecule of hyaluronic acid can bind about 50 molecules of water. In other words, we do not need to dry the root surface. This is very important. So it works. If we have a bleeding surface, it works even better. And this makes life easier for the clinician. So we place the connective tissue. Then I place another layer of hyaluronic acid. You can see again the same phenomenon. And then with tension-free sutures, I just close laterally, very, very simple procedure, and wait for the healing. This is a situation baseline. This is after about 2 years later. You see a very nice regeneration of the soft tissue. We don't see scar tissue formation. And we published the first data. It was just published this month, focusing only on lower jaw recessions. Only one surgeon did the surgeries. It was myself. And please observe that the complete root coverage was 50%. In other words, in 50% of the cases, it was covered until the CG. I think that this formulation of hyaluronic acid is a useful tool for being used in conjunction with periodontal surgery, because it may improve periodontal wound healing and even periodontal regeneration, and can be used in the treatment of intrabony defects, maybe combine it with some materials. We have to further elaborate on this issue, but definitely in soft tissue surgery.
Have been any effect on cell adhesion been observed? Any differences with regards to adhesion depending on cross-linking?
From a clinical point of view, it seems that if you have the cross-link formulation, it is more stable. Have you tried periimplantitis?
Okay.
Not yet. Is a good idea. We have to do a study.
Okay.
But I think it may have an effect if we are able to clean the surface. Maybe we should start first with mucositis before trying periimplantitis, to look how the material sticks on a titanium surface. And then definitely, of course, we have to remove the biofilm. This is the first step. But then we may need something to reduce the inflammatory response and to enhance soft tissue wound healing. And why not? I think is a very good thought.
What happens if iodine is in contact with blood?
It works even better. So this is one major advantage in the clinics. You don't have to bother whether your root surface is dry or not, because iodine or hyaluronic acid, because iodine is only one product. But if you take hyaluronic acid, these formulations, and you have a fluid, you have blood, it binds, it attracts the blood. So in fact, one molecule of hyaluronic acid binds about 50 molecules of water. And for this reason, it is very interesting in the tunneling procedure, because there I always had my personal difficulties in drying the surface. So if you use Emdogain there, it flushes out from the wound, and we have less concentration of enemymatics proteins. So this is, for me, something that also from a clinical point of view was very interesting.
Okay. For patients in need of both non-surgical and surgical therapy, can HA be used in both phases of treatment to enhance the results or the preparatory phase of the surgery?
Yes, I mean, we have also, I didn't present those data, but we have a couple of studies in the literature done with some other products, but also based on hyaluronic acid, that have shown that used in combination with scaling and root planing, that means non-surgical periodontal therapy, we have a certain improvement of probing depth, gaining clinical attachment level, and most importantly, less bleeding on probing. In other words, it positively influences the inflammatory phase. So, okay, what are differences in clinical outcomes? I mean, we have much more data with Emdogain, definitely. And I was one of the pioneers working with Emdogain since 1996. I treated my first cases. It is very difficult to compare because I have much less experience with hyaluronic acid, obviously. In intrabony defects, I don't have cases treated. We have only the animal experiments, but I have many cases treated with for recession coverage. And if I look the cases that I treated with recession coverage, I treated about 80 patients. The results are really fantastic. I would say at least the same, but we don't have direct comparative studies. Okay, it cannot only extrapolate from my experience.